My name is Divya Gulati and I have recently joined iTech team in Delhi. I, on behalf of iTech, welcomes all the participants for today's special NDLS session. Today's topic is recent programmatic updates and the speaker is Dr. B.B. Rewari. As you all know that Dr. Rewari has been involved with National ART program for over 12 years, right from the stage of inception of its program in 2004 till its implementation till date. It's our privilege to have him here for today's session. I would like to request Dr. Rewari to take over the session, please.
Good afternoon, everyone. It's my pleasure to be here again talking to you on the recent programmatic updates. We'll be talking on different topics today, and these topics cover some of the recent programmatic updates, which include revised guidelines on ART initiation. We'll be able to know and discuss the revised guidelines, understand the revised and simplified SACEP referral mechanism. We'll also discuss what is the revised monitoring evaluation tool to be used by SACEP. I will also like to brief you on the viral load testing and third line ART, and also give you some recent update on HIV collaboration that has been happening now. These are some of the very important changes in the program which will be useful to the PL-HIV in improving the quality of care, improving their life, in reducing their morbidities and also the comorbidities. Since there are different parts, some of these are unrelated to each other, I would request all of you to reserve your questions to the relevant part. The questions which I will not be able to or I may not be able to answer during the discussion because it is a lengthy session, will all basically send you the replies to all queries that come to this. This will be recorded and reply will be sent to you. So we begin with first revised NACO ART guidelines on first line ART initiation. I hope all of you have received this circular on the recent change, and some of the slides that you will see now you might have seen already in the training modules, in the training, the refresher trainings, maybe through some other NDLS sessions or elsewhere. There is a definite evidence that provision of ART early enough in the course of HIV infection has got benefits, as it leads to a more robust immunological response when treatment is initiated at younger age. There is a reduction in morbidity, mortality. Also, there is a decreased T cell activation and inflammation by starting antiretroviral therapy, and this leads to reduction in HIV associated nephropathy, cardiovascular diseases, AIDS defining malignancies and neurocognitive complications. It also reduces the risk of liver disease progression in people who are co-infected with HBV and HCV, and of course provision of ART by reducing the viral load also prevents the transmission of HIV. I will quickly go through some of the slides which have already been disseminated through various forums. Why we started ART at 200, 350, 500, why are we changing the guidelines over the years, and are these evidence based, and what is the evidence behind this? If you see the slide which you might have seen many times, as the immune suppression goes down, the CD4 count falls, there are different opportunistic infections that start coming in. And if you look at when the CD4 count is less than 500, basically you get most of the opportunistic infection, and when CD4 count goes below 200, then you get what is called as AIDS defining illness, and that was the basis for recommending starting ART when your CD4 count is less than 200 or the person has got a advanced immune suppression. Now moving on to beyond 200, there was a recommendation, why move to 350? This was based on a trial which is called CIPRA HT001 trial, which was done in a country called Haiti, which has got a HIV epidemic similar to our country, and this basically trial compared the outcomes when the CD4 count was less than 200 and when it was ART was started when CD4 count is less than 350. And if you just focus on this, there was a 75% reduction in the rate of death and a 50% decrease in incidence of tuberculosis when ART are started at CD4 count less than 350 compared to less than 200. Similarly, there were other studies which came up, and one of these studies were HPTN 052, another study was SMART trial, basically which again showed that there is a lower risk of death or progression of AIDS when the CD4 count for starting ART is changed to 500 compared to 350. So there was evidence for lower progression of AIDS from these clinical trials, which are randomized controlled trials, and also there was evidence from the observational studies in terms of benefit of early initiation of ART. So based on this, now NACO has adopted the guidelines which WHO recommended in 2013 that you start all PLHIV in clinical stage and 1-2, meaning thereby most of them will be asymptomatic. Start ART if CD4 is less than 500 cells. This has already been revised to 500 cells. Clinical stage 3 and 4 start ART regardless of CD4 count, meaning thereby any CD4 count, a person having WHO clinical stage 3 and 4, you start ART. Again, children below 5 years, they get ART at any clinical stage, any CD4 count. If they are less than 5 years and documented to HIV infection, basically they start at ART irrespective of CD4 count. Now the change that has been brought is from 300 to 500. Now the patient who are with you already in pre-ART care, but they are not on ART because their CD4 count was between 350 to 500, they should undergo a fresh CD4 count. That is very important, unless that CD4 count is within last 1 month. And they also should undergo baseline investigations like renal function test, because now we are starting all patient on a tenofovir based regimen. Also they should undergo 2 sessions of preparedness counseling, which is our existing practice before initiating ART. But these patients in pre-ART care may be coming to you once in 6 months only. So a reinforcement of the adherence counseling, side effects of the drugs, need for lifelong ART are very crucial for these patients. Again, for all pregnant and breastfeeding women, there is no change. Any clinical stage, trimester, start ART regardless of CD4 count as soon as pregnancy is detected. Just take a sample of CD4 and start. Do not wait for the CD4 count to come. Patient with HIV TB co-infection, whether it is pulmonary TB, which is stage 3, or it is extrapulmonary TB, which is stage 4, or even when patient has a past history of TB, start ART regardless of CD4 count. Start ATT first. Initiate ART as early as possible between 2 weeks to 2 months. So what is new here? The new thing is that for patient with CD4 count less than 50, start ART simultaneously with ATT. Earlier we were saying start ATT, stabilize them, initiate ART after 2 weeks, but now we are saying because the immune suppression is significant, CD4 count is less than 50, they may die before ART initiation. So start ART and ATT together, but remember there are overlapping toxicities between ART and ATT, so it is very important that there is a strict clinical and laboratory monitoring. Also, I have been asked this question, patient with past history of TB should be started on ART regardless of CD4 count, and that is how past, 1 year back, 2 year, 5 year. Our answer is anytime after he was found to be positive, he had TB, you should start ART regardless of CD4 count. Then those people who have got HBV, HCV co-infection but do not have any evidence of severe chronic liver disease, start ART like any other one if CD4 count is less than 500. HIV, HCV infection with severe chronic liver disease, start ART regardless of CD4 count. Again, what is new, which may not be applicable to all centers because they may not have so many patients with visceral leishmaniasis, but wherever they are, patient with HIV, Kala-Azar co-infected, they should start basically ART regardless of CD4 count, even if they have a past history of being treated for Kala-Azar. You know, there are 56 districts in the country in 4 states which are endemic for Kala-Azar, and this initiation of ART is likely to reduce their recurrence of visceral leishmaniasis, also improve their outcomes in terms of reduced mortality, just like we give it for TB and HIV co-infected persons. Now just to tell you how over the years we have seen the guidelines have been changing. When the first guideline came in 2004, we only had some studies like ACDG studies, CPCRA studies that initiate CD4 count less than 200. Then based on CIPRA and SMART, we moved to CD4 less than 350. And then we had studies which provided us evidence that moved to CD4 less than 500 even for asymptomatic patient. Now there are other studies available called Temprano studies and START trial, basically which recommend that we should start CD4 ART at CD4 less than 500 cells, because it has got again a definite impact on severe HIV morbidity, disease progression, and there are no additional side effects even if we are starting ART in asymptomatic patient, though this has not come into guideline. So if we summarize over the years as the guidelines has evolved, we have been moving to earlier initiation of ART based on the evidence available from randomized control trials, which basically offer us a strong evidence for moving to higher CD4 cutoffs. We have moved to simpler treatment. You are all aware that now we are using a single pill of tenofovir, lamivudine, efavirenz for adults, for pregnant women, for hepatitis patient, for TB co-infected patient. Second line regimen are simpler now. We have got heat stable formulations, and we are now moving towards a viral load monitoring and third line. Basically, these guidelines for moving to more than 500 are still not implemented in the program, while third line has been initiated and viral load testing is in place. But this was more on when to initiate. Coming to what ART to initiate, basically the guidelines do not change. I hope you have this OM, you have gone through this office memorandum, because you are initiating new patients on ART, and all new patients eligible for ART as per CD4 cutoff of less than 500, plus those with TB co-infection, hepatitis co-infection, pregnant women, children less than 5 years, regardless of CD4 count, have to be initiated on regimen, which is a single dose, single pill, fixed dose combination of tenofovir 300 mg, lamivudine 300 mg, efavirenz 600 mg, given once daily at bedtime and avoiding the fatty food. These are the similar guidelines which were rolled out in November 2014. Patients who are already on existing on zidovudine based regimen continue on ZL and continue on the same regimen. There have been a lot of questions coming to us about the delay in the SACEP mechanism. The network of positive people, other people have been giving feedback that SACEP referrals are delayed. Referral to SACEP should not be delayed, because if you delay the referral, it compromises their second line ART and they may fail earlier. Why we basically simplified this mechanism? We want to improve access to second line ART, make it easily available nearer to patients' residence, and also want to improve their adherence, because they get ART second line nearer to their residence. Adherence will be better, and this will cut out on the traveling time, cost to PLHIV. Many of them cannot afford even traveling to a nearest ART plus center or COE. But what is more important, which you need to focus, and I would like to take this opportunity, that early suspicion of treatment failure is very necessary to ensure timely management. We have seen that I've just got a question, what is that decide in adult patient between 25 to 35 kg? Will reply you on mail, but these guidance have already been given. I had requested people to focus on the session that is being given. Patna MCH, please note we are discussing the revised SACEP mechanism. So you focus on the current, you can keep on asking question after the session which will be replied to you. But this will derail if I go on to questions which are unrelated. What I was saying now, that basically we are not getting patient timely referred to COE ART plus center for various reasons. Initial reason was distance to COEs. So we expanded ART plus centers to each state. Now we expanded them to 100 centers providing second line ART. But still people were not being referred in time. Wherever I visited in last 3 months, I have seen even when there is a ART plus center there itself, even their own patients are being referred. Even in Delhi I have seen this, their own patients are not being referred timely. There is a delay of 1 to 3 years. This is actually a criminal negligence which is going to patients, affect the patient's future options for the treatment. So my earnest request to you too is always look at the CD4 count of the patient, see the last CD4 count. If patient has got immunological failure, please refer them urgently. Now coming to problems in the SACEP referral. ART center has to refer these patients with suspected failure based on either immunological criteria or clinical criteria, which I know are well known to you. SACEP has to verify this record, basically give an appointment, request for viral load, and then based on the viral load report, permit the nodal officer to initiate second line ART. So when we say refer them early, we know that there are different type of criterias. the CD4 immunological criteria, clinical criteria. Fall of CD4 count to pre-therapy baseline level, or 50% fall from on treatment peak value, or persistent CD4 below 100 cells. Any one of these means patient has got immunological failure. We have been asked this question whether this should be all. No, it is or. So either a fall to pre-therapy baseline, or 50% fall, or persistent CD4 below 100 cells. Divya, I am getting a call that audio is not clear. Can you please check the internet? Okay, coming back to clinical advancing T stage, occurrence of a new opportunistic infection or malignancies, WB SACS. Again you are debating, you are asking when additional TLE supplies will be supplied. For new guidelines, the supplies are already in place. Today I have checked that there are 3.53 months of TLE across the country. So you don't have to worry whether TLE for new guidelines is available or not. But again, coming to revised guidelines, since you have asked this question, we are not proactively calling the patients in pre-RT. As and when they come to know that they are now the criteria has been changed, or they have come for their routine CD4 6-monthly count, only then we initiate. Divya, Anamika is saying there is no sound. Please check. Occurrence of new OI or malignancy, recurrence of previous OI, onset or recurrence of WHO clinical stage 3-4 condition are clinical indicators of a treatment failure, a suspected failure. Similarly, in children, CD4 falling to below 15% for age 1 to 3 years, below 10% for 3 to 5 years, or one of the 3 adult criteria if children is more than 5 years. Similarly, the clinical are advancing T stage. T stage is WHO staging while on treatment, like occurrence of new OIs, opportune malignancies, recurrence of previous OIs, onset of any WHO stage 3-4 condition, or a growth failure or a progressive developmental deterioration. I would like you to lay your attention on this particular graph. This graph is indicating very clearly when a patient starts failing on the treatment, his viral load starts going up. But it keeps on growing for a while, and the virus that is present in the body keeps on destroying the CD4 count, but that CD4 count diminution takes some time, that decline takes some time. If you see the timelines, the viral load is increasing, but after around a period of 6 to 12 months, you will see a CD4 decline, and clinical failure basically you will get after another 12 to 18 months. So basically when a person is failing treatment, we should actually be catching them when they are really started failing for second line regimen to be effective. But we are not doing a routine viral load as of now, so it becomes very crucial that we do our CD4 count regularly. It is very, very crucial that CD4 6 monthly is done, and not only done, it is recorded, and not only recorded, it is looked into it. At many places it is recorded. I have seen CD4 count of 2014 below 50%, below baseline, they are being referred in 2016. This 2-year wait will lead to accumulation of mutations, and your second line will not be effective. And of course, when person is referred with a clinical failure, already he will have very significant viral load. So if you remember this graph, it is very important that you catch them early, at least with regular CD4 count, but very soon we will have a regular viral load facility available at ART center, which I will detail later. So now the protocol is similar. Once you have suspected failure, you have to see patient is on ART for 6 months or not, because you generally patients don't fail below 6 months, as our transmitted drug resistance is very, very low. But they may fail not only because of treatment failure or resistance, they may fail because of poor adherence. So you have to see whether adherence is optimal or not. If it is optimal, basically then you have to see whether the CD4 count is recent within 1 month. If it is indicating, immediately person has to be referred to SACEP. Now in SACEP there were delays of months together because patient had to travel, patient was not able to travel. So now the 10 commandants, we call this as 10 commandants of referral. 10 commandants are ART center will refer cases through email, COE or ART Plus will review this and give 2 suitable dates by email, and then patient will visit as per given appointment, and SACEP will recommend viral load. There is no change in this. This is the existing mechanism as of now. What is changed? Fourth is sample of a viral load will be collected presently at COERT Plus center. This is a barrier because patient will have to come to COERT Plus for viral load testing till it becomes available at all centers. Now focus your attention on the point fifth. Now if patient has come once, he has been reviewed by SACEP, he has got a viral load sample taken. In next visit, whenever viral report is available, this will be reviewed by SACEP in absentia. Patient will not be called. Presently patient is being called again. And instructions will be given to referring center through email and feedback form that this patient requires a change of regimen to second line. What is the dose? What is the toxicity monitoring required? Or he does not require a change, or you send back after 3 months, and other relevant information will be given to the referring center and to SACS and RC to provide drugs at patient's own ART center. Again, see, this is the change. Dr. Rajashekharan has very beautifully highlighted in slides all the changes in the red color. Second line ART will then be initiated at the parent ART center. This is very, very different from current mechanism, whereby we transfer out the patient to COE or ART plus, then they remain there for 6 months, then they go back. This is one of the hindrances in second line ART, which has now been addressed, that second line ART will be initiated at parent ART center. No transfer in, transfer out. Patient will have to go to COE ART plus center once only. So you have to tell your patient that if you are having a suspected failure, you will be evaluated at a higher center, which may be COE or ART plus. Your viral load sample will be taken. Rest of your treatment will be at our own centers. However, in some situation, there could be some critically ill patient. They may require indoor admission at COE. That will be reviewed on case-to-case basis. So patient will be followed up at parent ART center itself. They will come back to SACEP for viral load repeat at 6 months as of now. But in 6 months, we hope that viral load facility will be available at all ART centers, all 528 ART centers. So they will not have to come. They will undergo a viral load, repeat viral load at their center. Lucknow, second line drugs have been sent. They have been sent to all centers now. Now once the information has gone to the referring center that basically now you have to start second line in this patient, CST focal point, SACS has to note that they will have to send these drugs to concerned ART. For the high load centers, SACS should ensure the drug for 2 to 3 new patients are already available at center and they are replenished as per requirement. So detailed instructions are being provided on the revised tools and cases with problems. Again, this is very important. ART plus do not have to refer any case to SACEP. ART plus has to refer all cases to their SACEP at their linked COE. All 520 ART centers are linked to 100 odd, 87 odd ART plus centers which are linked to COE. So the linkage is of ART center to ART plus to COE. And if COE has got any problem, they can refer their query to SACEP. This has been very clearly conveyed in Office Memorandum of 26 May 2016. If you have not got it, please ask your data manager why it has not been given. There is a good question from Capital Hospital. If adherence is unsatisfactory, no. If adherence is unsatisfactory, then immunological failure may be because of poor adherence. Then you don't have to refer the patient. You have to improve the adherence counseling, repeat a CD4 count after 3 months, and then only you refer. There was a question which came up to me in one of the recent visits, that some of the centers, ART plus centers, are not accepting referrals if it is less than 95%, even if it is 94%. Capital Hospital, the optimal adherence is 100%, but it is acceptable up to 95%. But if it is 94%, 93% in last 2 visits and it has been good earlier, then there is reason for ART plus center to refuse. Is that clear? So 95% is optimal. Sometime 1 or 2 in last 6 months, you have to look at last 6 months. 1 or 2 are less than 93% for some reason, 90%, 91%, still SACEP should if viral load is not detected, there is a question what should be stand of COE ART plus center. I think the guidelines are clear. If there is a immunological virological discordance, the guidelines are very clear that you look for HIV2, look for other causes, look for hepatitis, and then basically refer the patient again. Now there is a bigger role for SACS and the regional coordinators. The optimal who is sir? Motiwari. Optimal means 100%, but up to 95% is acceptable. So the CST focal person at SACS, it may be JD, it may be DD, it may be AD, they will ensure that emails sent by a COE ART plus center. When COE or ART plus center will initiate patient, they will intimate their referring center. They will copy that mail to SACS also, to focal person at SACS. And SACS will ensure that immediately drugs are made available at ART center, and for that drugs for 2 to 3 patients will have to be made available in advance and replenished regularly at ART centers. Coming to the tools, these are the standard tools which are available. We are not changing, there are minor changes in the tools. First is RRF, referral reply form. It is kept at all ART centers. It is to be generated at ART centers, and it is a triplicate form. I will come to it later. Your second tool is consent form for second line, which has to be obtained from each patient by the counselor when starting second line ART. It is a computer printout again. Signed form should be kept in a ring binder file. There is no change. It is the existing guideline. SACEP register. Very important. All patients being referred to SACEP should be entered in the SACEP register, which is to be maintained by COE, SACEP coordinator, or by ART plus data manager. Again, hardbound register is to be supplied by the SACS. Many SACS are not supplying this. They are supplying incorrect. If you don't have the right format of this, we'll supply you. And again, it should not be too crowded. The guidelines have been given already for that. SACEP meeting format is a very vital format which should be made available to all SACEP members before the meeting so that they can be reviewed properly. It has to be prepared by SACEP coordinator or by data manager. Then there is a monthly reporting format which is to be submitted. Now the change is all ART centers have to submit this. Earlier we were compiling this from COE and ART plus, but now second line data will be compiled from ART plus all 520 ART centers. And then there is a referral form. It is to be maintained by all centers. Okay, Capital Hospital Bhubaneswar. Repeat the answer to question if adherence is unsatisfactory. I have said if adherence is unsatisfactory, we should not refer. We should be clear what do you mean by unsatisfactory. It is not 94%, 93%. Suppose it is 80%, 85% and has been not adherent for last 2 or 3 months. First we have to find out what is the reason why the person is not adherent. Such patients require special counseling session. And we need to improve their adherence, and once adherence is improved, there are chances that immunological count may improve, CD4 count may improve. So we will wait and not burden the center or the patient unnecessarily if this failure is likely to be because of poor adherence. Of all the tools that I have mentioned, only SACEP register is to be printed as hardbound register. Rest are to be kept as soft copies. Printout has to be taken. And again, Anindya Sen, I have very clearly said that third line will issue when discuss when the third line drugs are come. We are on SACEP only. We are not discussing third line here. So these tools have to be kept out as soft copies, kept in a separate file at ART centers other than SACEP register. Now coming to each tool, RRF is a request form to SACEP. It is a triplicate form which has got 3 portions. How many were there initially? 2 portions. Now what are the 3 portions? First is request to SACEP at COE or ART plus center for review of a patient, which is sent electronically and then sent with the patient. Second portion is reply from SACEP to referring center. Okay, we have reviewed your patient. These are the guidelines. Start second line, do not start second line, send for repeat viral load, check for HIV2. Then third portion is reply from referring ART center back to COE after the approval. There is no change. This is a request form. Basically Only thing that has been added is a suspected second line failure in this. Rest of the form is mostly the same. Coming to reply, again this is reply from SACEP that what is the treatment plan. Earlier it was what is the treatment plan, and the patient was asked to be transferred out to COE IIT Plus Center, which is not asked for now. Now the treatment plan is given, signed by nodal officer with contact number and email for any problem, so that the center can contact them. Now this is the third part. This is the third part. Basically it is reply from referring center that SACEP had recommended this particular recommendation for this patient. Now what action we have taken, like, okay sir, we have started this second line ART. Sir, we will send the patient back after 3 months. Sir, we will look for HIV too because there is immunological virological discordance. So the name and signature of nodal officer of ART center has to be on this. These have to be sent as a scanned copy electronically. Consent form, there is hardly any change. Some minor changes are there. This is to be taken for all patients starting second line ART. In we will club this with the first line also. Just devise one common consent form for ART. Now coming to SACEP register. Again, SACEP register is to be maintained by SACEP coordinator. It should be complete. All information should be up to date. If some particular section is not applicable, you should place just a dash in that section and not leave it blank. And SACEP number should be a serial number depending on the ART. Sunil, again I think we have not discussed about the drugs of lamivudine toxicity. It is very clearly said earlier also that CO is responsible for single drug purchases. We have asked SACS to purchase. If SACS is not able to purchase, it is COE or vice versa. Now coming to the SACEP register, this basically shows the whole register in which there are two portions, the left side and the right side. I will focus on the left side first. This is on the left side of the register, and the right side we have given the size of the register, thickness of the paper and everything that has been given. Basically we have to now look at the reason for the referral. Reason for the referral can be suspected treatment failure, it can be side effect of the drugs, it can be on second line ART from private, and it could be other. Again it has to have a latest CD4 count with date, which should not be more than 1 month old, and again the clinical stages and functional status. Now coming to the right part is the recommendation of the SACEP. The SACEP recommendation should be very clearly said that recommended for second line ART, substitution with PI containing regimen, substitution with TDF, substitution with other regimen, management of complicated cases, because SACEP is not only for second line, it is for complicated cases also. And we have seen many centers sending referral for complicated cases, which can be electronic referral, which can be patient also. Accordingly, the feedback is given. Coming to SACEP meeting format, this format is basically should be available to all members. Basically, when they are meeting for this, it should be a printout and it should have a summary at the end. Summary should be how many total patients were referred, how many were supposed to attend, how many actually reviewed, how many were recommended for viral load, and total number recommended for second line ART from above viral load, but this will be done after the viral load. So in the initial meeting, it will be basically filled up 4 column, but for old cases, it will be the 5th column also. How many patients have been recommended for second line ART. Again, this is the upper half, giving it in more details, and then basically more details on basically patient reviewed, actually reviewed, recommended and recommended for second line ART. Now coming to monthly progress report, this format has been changed, has been sent to all the centers. You see, it is just a replica of your first line format. If you look at, this is the cumulative number of PLHIV referred to SACEP for assessment at beginning of this month, number of new patients referred during this month, total of beginning of this month, new patients, how many patients this is referred, this is again a cascade, how many of the referred were given appointment, this will be out of this, out of how many have been given appointment, how many actually reviewed, out of reviewed how many were eligible for viral load. meaning thereby they had a true immunological failure or a true clinical failure, adherence was good. What is the cumulative number of PLHIV who underwent viral load? What is the cumulative number of PLHIV found eligible for second line at the beginning of this month, during this month, and total cumulative number? So it is exactly the same which is for the first line ART. I will just stop here and take some question. Is there any provision to enter ineligible patient? Yes, all patients who come to SACEP should be entered in the SACEP register. Later on, whether appointment given or not can be entered. Patient who are given appointment but do not come, what date should be mentioned? ART center, it is a responsibility of ART center to ensure that patient comes on one of the two dates that is given to him. But if he is not coming on first date, a communication should be sent to him to come for the second date, and this should be mentioned in the register. New patient already on second line ART from private wish to come under, should the case be? Yes, we have to take approval of the SACEP, what regimen were there, why this regimen was started, what is the current viral load, they should be. Again, coming back to the reporting format, cumulative number of patients who were started on second line ART, who were started at the beginning of this month. Okay, we are getting the questions, so we'll be able to answer if we have time now. But I am only halfway through my presentation, and it's already 35 minutes. So what is the cumulative number of patients ever started on second line ART? Number on second line in this month, cumulative number transferred in, transferred out. Cumulative number ever started, that will be again a total of this minus those who have been transferred out. Similarly, died, stopped treatment, LFU, did not return, miss, and number shifted to third line. This is a change. Some of the patient of second line may be shifted to third line. You remember, we have opt out, stopped treatment, LFU, miss, died in first line. Now we have a cumulative number of patients shifted to third line, because third line patient will be accounted separately. Presently in your MPR, in total number of PLHIV, you were including both first line and second line. So ultimately its total number of patients alive on second line ART. I think this is quite simplified, has been done basically on feedback from all our regional coordinators and many of the ART centers. Okay, there is a question. Any PLHIV on second line drugs for more than straight away by private specialist case of CMV retinitis who attended DSF with low CD4 count, what shall we do? If he is already on second line for more than 1 year, you don't have to change the regimen. He continues on the same regimen which is available in our program. If it is not available in our program, then we have to take consent of the patient that I am ready to take the regimen which is available in the program, as my present regimen may not be available in the program. It has to be a written consent for the patient. What is the basic difference between criteria for a second line and alternative first line? Alternative first line, I think BMCH, you have to understand the difference between the switch and the substitution. Substituting one particular drug for toxicity, we call it alternative first line. Second line is if you are changing the whole regimen of the patient because of treatment failure, you are changing the total regimen, that is called switch. Second line is also the regimen which patient is using after he has failed on the initial regimen. Some of the patient might have started on a second line regimen to begin with, but mostly patient will start on a first line regimen, fail, and then they will go to second line. So second line is the subsequent regimen which patient basically he has failed on his first regimen, whatever that regimen is. Rama Pandian, yes, we are working on viral load testing. Please wait for the next viral load. I have given you in my initial that I am going to do with ART initiation, with SACEP, with viral load, third line, and HIV TB. So please restrict your questions accordingly. Okay, now this is the referral summary which you have to maintain at your own center. You don't have to send it unless it is asked for. This is basically for your own referral, how many patients you referred, how many patients basically attended, and how many patients were recommended, how many patients were started, and what are their outcomes on treatment, dead, LFU, others. So this is to be maintained. So this was more about the SACEP simplification. I think every center needs to look into the clinical failure, which many centers are presently not looking. I'll give you analysis from a particular study, a rough desk analysis that we did at NACO with our technical officers and program officers, that our failure rate are around 1.5 to 2%. We should have roughly 50,000 patients on second line, while we have only 15 to 17,000 on second line. Because patients are not being suspected earlier, not being referred for various reasons. So it is very important when you are doing your job, do it right, do it with full conscience, see that you are not harming the patient just by writing CST, continue same treatment, repeat all. You are harming the patient if you are not looking at their CD4 count and timely referral to second science. Now I am coming to viral load. Viral load, there has been a demand. Viral load is the standard of care. I had shown you that graph. Basically, when a patient starts failing, his viral load goes up first, and then it is a CD4 count which declines, and then patient gets clinical symptoms. Remember that graph always. We also remember them as program managers. So we have been trying for many years to get viral load testing, but you have to understand there are 9,55,000 patients on the ART centers. There are only 10 viral load testing facilities in the government. They are doing 10,000 tests only. So no first line failure earlier. We require a viral load test, and now we are rolling out viral load testing facilities on a turnkey basis. And for doing 9,55,000 tests, we have to prioritize. We cannot go from 10,000 to immediately to 10 lakh patients. So we have to prioritize patients who are on ART for long time, more than 5 years. All HIV positive pregnant women, all children on ART basically will be prioritized for viral load testing in the first phase. Similarly, we will be prioritizing 210,000 tests in first year, 250,000 additional tests in second year, and last year we will have around 8 lakh tests being done for viral load. And for this, lot of efforts have been done. Funding is available. To tell you, it is not that viral load is not available. Funding is available. The document has been prepared, and this will be put urgently now in next 2 weeks for tendering. Now I will take some questions. If patient comes from private on second line, how do we decide to start first line? Siddharth ART Center. If this was the first regimen started for the patient, suppose this second line regimen, when you say second line regimen, I understand it was a PI based regimen. We continue the same regimen. If it becomes first line regimen for him. Any regimen which is started for the patient at the initiation of ART is first line. Any regimen which is changed because of treatment failure is his second line regimen. Some patient in private clinic were started with boosted PI in Reltagravir. Now they want, no, we cannot provide. We cannot provide boosted PI Reltagravir as our first line. It is our third line regimen and restricted for patient with treatment failure. Yes, if they were started on boosted PI Darunavir, Ritonavir, Reltagravir because they failed on their earlier regimen, so it becomes a third line for them, and we will be able to provide even if they are taking this in the private sector. So I will clarify again. If a person is on Reltagravir, Darunavir, Ritonavir or for third line ART, it was started because he was not able to get it from us, we will take him. But he was started this as a first line regimen or second line regimen, no. Okay. A person registered in SACEP for alternative first line after some time CD4 decreased, then referred for suspected treatment, calling another number. SACEP register number remains the same. Okay. We move on now to the next topic. Guidelines for provision of third line ART. Again, the mechanism is referral to SACEP. Third line ART is only available at 10 Center of Excellence as of now. There is a new change. All PLHIV on second line ART should undergo viral load testing after 6 months. Current scenario, we are talking only targeted viral load is available. As of now, we have targeted viral load. All PLHIV on second line should undergo viral load testing after 6 months. If viral load is less than 1000, it is continued. But if it is more than 1000, then again we look back to CD4. This is not optimal, but we again look to CD4. Whether this CD4 is below pre-second line treatment, below 50%, below 100 for 2 consecutive tests, then it should be suspected as a second line failure. This will change when we have got a routine viral load available at all ART centers. So this might change in the next 6 months, but as of now, All cases who have got suspected failure should again be looked for adherence, looked for opportunistic infection, and then referred to COE electronically with referral form. And if adherence is poor, major O is identified, again improve adherence, treat OIs, do not refer them till you have treated the OI or adherence has been improved. COE will give again 2 appointments, patient will again visit COE as per appointment, will be reviewed, and again SACEP will refer for viral load if it has not been done. Viral load report will be reviewed by SACEP again in absentia, patient visits only once for review. But if PLH is, our viral load is between 1000 to 10,000, then we have to get this viral load done again after 1 month to confirm failure, because there can be some blips of viral load in between. And PLHIV are found eligible for third line will be given appointment. Now these PLHIV will have to come to COE for third line. Third line will be initiated COE only. This is like we started in 2008 on second line ART. What do we use in third line? We use 3 drugs. Reltagravir 400 mg, darunavir 600 mg, ritonavir 100 mg. Both of these are to be, all these tablets are to be given 1 tablet twice daily. We have got reltagravir separate and darunavir ritonavir as fixed dose combination. Patient will continue third line ART from COE for at least 3 months. If he is stable, adherence is more than 95%, can be referred to nearest ART plus center. Remember that COE will initiate third line. It will be maintained at COE or ART plus center, not at respective ART center as of now. So once the patient is stable, he can be transferred back to nearest ART plus center. Shortage of CD4 printing paper. Again, it is not relevant, Karimnagar. Please ask it later. If you have any questions on SACEP, ask those questions first. Capital Hospital. Poor adherence with signs of immunological failures plus signs of clinical failure should be referred to SACEP. If a patient is failing immunologically and is also patient is failing clinically because of poor adherence, there is something wrong with your counselors, something wrong with your doctors, that you are having a patient with such poor adherence that he has failed immunologically and he has gone to a clinical failure because of poor adherence. Please focus on the counseling. So third line ART will be initiated by COEs themselves, but COEs will also refer the cases to SACEP if it is a complicated case. If patient is referred from private center for third line, multi-NRTA exposed cases, any intolerance to third line drugs, cases requiring these drugs as alternate to second line. Some of the patient may be requiring only reltagravir with boosted PIs. Presently we are not providing, but such cases should be referred to SACEP or any other case as is required by SACEP. Once the decision for starting third line ART is done, patient will be transferred out to concerned COE. This is similar to what we used to do in second line. Since we have advanced now, second line we are not doing transferred out. We are now transferring out only patient requiring third line, and patient wise details of this patient initiated on third line by COEs should be sent to NACO every month, so that we have a count of the patient and the drug stocks. Now what is the role of SACS and RCs again? Supply chain management for third line ART will be managed by COE presently for the initial period. Instructions regarding same will be sent as and when required, and SACS representative will also participate in SACEP, because SACEP will be for third line will be only at COEs, so SACS representative must participate. Now what are the possible side effects? Possible side effects of reltagravir are rash, hypersensitivity, SJ syndrome, nausea, headache, diarrhea, fever, muscle weakness, but more or less we have seen these in very few patients. The literature also shows that these are not very common side effects, but our centers hardly have exposure to these drugs, so we have to be careful for such symptoms. Similarly, darunavir, it has got a sulfonamide moiety, so there are more chances of skin rash which can be as high as 10%, SG syndrome, TEP, hepatotoxicity, hyperlipidemia. Again, ritonavir we have used extensively. We know that there are gastrointestinal disturbances, neurological disturbances, but more these are gastroenterological diarrheas. So we have to remember, when we are starting new drugs, we are very clear we should be knowing their side effects and keep an eye for the side effects for the newer drugs. Okay, I'll see. Yes, you will get this presentation by email also. You will get this recorded link also. And third line patient should be kept at ART plus center also, I have clarified. Let me see if there is anything else, because I have 10 minutes only for HIV TB. Okay, we'll answer you later. I have got still 10 minutes only, and I want to tell you more about TB and HIV TB also. So, as you may be aware, some of you, that we are now moving to a daily regimen for antitubercular treatment. When I say daily regimen, we were using this current regimen, whereby we were giving a intermittent therapy. There are two phases here, you see. This is 2 months is your intensive phase and 4 months is your continuation phase. And there are only two types of TB patient now. It is so much simplified. All TB patients who have never had treatment with anti-TB drugs, mind the word drugs, or has taken it for less than 1 month, are called new patient. And those who have received 1 month or more of anti-TB drugs, they are called previously treated patient. So they were presently getting 2 months of HRZE, I think you know, isoniazid, rifampicin, pyrazinamide, ethambutol. They were receiving 2 months of these on alternate days and 4 months of INH and rifampicin. Similarly, previously treated patients were getting 5 drugs for 2 months, 4 drugs for 1 month and 3 drugs for 5 months. This is the current regimen that is being provided for HIV TB co-infected. Duration for these was prolonged in patient with extrapulmonary tuberculosis like TB meningitis, TB spine, other forms. Duration was extended to 9 months. Also, there was a change. In TB meningitis, we were using streptomycin instead of ethambutol. You don't see ethambutol here. So I would like you to type why were you not using ethambutol in such cases, why we had changed to streptomycin, while for TB spine we are using ethambutol, other forms of EPTB we are using ethambutol. Why it has been changed to streptomycin? I would like somebody to type it during the course of discussion. When we are talking of basically efficacy of anti-TB regimen, what do we want from TB? We want a better treatment outcome. So what is a better treatment outcome? Better treatment outcome could be a early outcome, a long-term outcome. Early outcome is basically high sputum conversion. Just to clarify, sputum conversion is the conversion of a sputum positive patient to a sputum negativity at the end of 2 months of intensive phase and 3 months in case of other. We want a high sputum conversion rate, and conversion rate is basically percentage of patient who were sputum positive initially and who became sputum negative among those who were started on ATT is the sputum conversion rate. What is then high treatment success? Sputum conversion at 2 months is also a success, but what is high treatment success? It is basically sputum positive patient who become sputum negative at the end of 2 months and also at the end of treatment. When they are sputum negative at 2 months and at the end of treatment, it is a treatment success. But besides this, we also want basically low relapse rate and also a emergence of low drug resistance. Drug resistance should be minimized in such cases. Don't look at this slide. I put it, some of the people will say what is the purpose. The purpose is only look at these two squares. Basically, if you see odds of relapse against new smear positive TB patient notified, you will see India, the percentage of patients relapsing is 15% compared to other high burden countries excluding India, which is 7%. So more patients in India are relapsing. Let us hold on for this right now. Let us look at this. Again, of all patients which are notified across the globe, almost which are new smear positives, 30% come from India. 30% of all new smear positive cases across the globe comes from India, and 50% of all relapse cases come from India. So you have a very high relapse rate, 50%, meaning thereby these patients continue to be positive and continue to have TB and they continue to transmit. Okay, I think you have understood this. Just to re-emphasize, in a study conducted from South India by Thomas et al., the relapse rate is 12.3%, other study shows 10%. So odds of relapse relative to daily regimen was 2.8 for 3 weekly intermittent regimen, meaning thereby relapse was very high, 2.58 times high if we are using thrice weekly intermittent regimen compared to daily regimen. And we currently have a study which is ongoing. It is a randomized controlled trial basically, which is now looking at daily ATT versus intermittent ATT regimen, and interim analysis is available. Again, don't look into minute details, just look into two red and blue curves. If you see the sputum smear conversion rate with daily ATT is 51%, is 63% compared to 51%, meaning thereby with daily ATT you have a higher sputum conversion rate, smear conversion rate. Similarly, for a culture conversion, it is 93% with daily ATT compared to 82% with intermittent. So there is enough evidence available that daily ATT is better. Vijayawada, yes, you have given good answer on TB meningitis. Because of inflammation, the blood-brain barrier ethambutol does not cross, whereas streptomycin process. Many people have replied. Okay, thank you. So we have enough evidence. Based on the evidence, we have taken different approvals: Joint Monitoring Mission, Standards of TB Care, committees, expert committees, many technical working groups. Finally, we have reached where Standards of India TB Care in India were devised. There were 26 standards. I would request you to go to this booklet. It is not a thick booklet. Then out of 26, the number 7 standard pertains to first line ATT regimen, and it very clearly says give HRZE for 2 months. Continuation phase should have HRE. If you have seen previous slide, it was only HR, because there were evidence available that up to 15% patients may have a baseline INH resistance. So if 15% patients have got a baseline INH resistance, then in continuation phase they will be taking only rifampicin virtually. Though they are given INH rifampicin, they are taking rifampicin only. So we have added now ethambutol. So the continuation phase has got 3 drugs, HRE. These are given as per body weight, done in daily regimen as fixed dose combination. So TB patient definition is same: TB patient which has not had treatment with TB or less than 1 month, previously treated more than 1 month. So it is 2 months of 4 drugs with 4 drugs of 3 months. Again 2 months of 5 drugs, 1 month of 4 drugs, and 5 months of 3 drugs. So these are the recommended regimen. Earlier we had 3 weight bands: less than 30, 30 to 60, more than 60, but this led to some overdosage of INH. So now fixed dose combination, just like ARV drugs, we have got fixed dose combinations of INH rifampicin ethambutol pyrazinamide, of INH rifampicin ethambutol, which are called now basically FDCs, which are 4 drug FDCs, which have got rifampicin, ionized pyrazinamide, ethambutol. There are 3 drug FDCs which have got rifampicin, ionized ethambutol. These all will be told to you in the recent training happening. I am not going into detail, but now the dose is according to weight. There were earlier 3 weight bands only: 30, 30 to 60, more than 60. Now we have got 25 to 40, 40 to 55, 55 to 70, more than 70. And accordingly, for intensive phase, continuation phase, these are the number of tablets. So just one example: a person weighing 50 to 70 kg, 69 kg will get 4 tablets of HRZE fixed dose combination for intensive phase and 4 tablets of HRE in the continuation phase for 4 months. We have more opportunities because all ART centers are undergoing training on this. We have learned that current intermittent ATT is not able to restrict relapse rates. They are high. Treatment outcomes are compromised. Standards of TB care have been developed. Continuation phase of daily ATT has been strengthened with addition of ethambutol to earlier INH rifampicin, and FDCs are made available. So we are having training, 22 training workshop for this, where you will be getting repetition of these slides, so I am not focusing a lot. Last focus is basically on intensifies case finding. 4 main TB prevention strategies are intensifies case finding, early ART initiation, IPT, airborne infection control. Quickly going, always look for patients who have got possibility of having TB using a 4 symptom complex, fast tracking them, diagnosing them early, and these 4 symptom complex which have already been communicated to you, that for adults it is current cough, any duration, fever, weight loss, night sweats, and for children these are current cough, fever, poor weight gain, not weight loss, but contact with TB case. Based on this, these patients have to be fast tracked. I'm not going into the detail of this complicated thing, you can look at it, but this has been sent to you. All the patient has to be fast tracked to a staff nurse, who will fast track to SMO, who will be fast tracked for diagnosis, and TB is diagnosed. Basically, then a rifampicin sensitivity test will be done, and accordingly patients will be managed. Continue for 2 more minutes. Screening should be done at all visits, to be done at pre-ART registration, ART initiation, monthly visit, by the care coordinator, by all staff, and patient with any of these symptoms have to be labeled as 4S positive and fast tracked by care coordinator to staff nurse, who will fast track these cases. And again, these cases, very important, will undergo TB diagnosis by CBNAT, cartridge based nucleic acid amplification test, or what you commonly may be knowing as gene expert machine, for which only 1 spot sample is required, so that patient will have the same day testing and same day availability of result within 2 hours. In case CBNAT is not available, then we have to do smear microscopy where 2 samples will be required, but CBNAT is being made available to almost all the facilities. Then patient will be categorized as new patient or previously treated patient and treated by ARTMO. That is very important. ARTMO will be treating these patients. They will be initiating these patients if they are not RIF resistant. You will have gene expert machine saying TB detected, rifampicin resistant detected, not detected. If there is a rifampicin resistant detected, basically they should be immediately referred to a drug resistant TB center and they will be taken care of at that time. These drugs which are being dispensed for ATT are for 28 days. They are to be dispensed for 28 days. So due date for ART has to be adjusted according to this. So this patient will get ART also, though a 30-box pill, but he will be called at 28 days. So the end of the TB treatment, that is after 6 months, leftover ART pills will be adjusted while giving the due date. So basically there is a definite, another part is basically provision of isoniazid preventive therapy. Because 50% of adults have got a latent TB infection, isoniazid has been shown to be very effective bactericidal drug and protects against progression of latent TB to active TB disease. And there is definite evidence that providing IPT along with ART has got additional benefit in addition to starting ART earlier. So all adolescents living with HIV who are screened for TB, who do not have, remember, who do not have current cough, fever, weight loss, are unlikely, and night sweat, are unlikely to have active TB, should be offered IPT. Similarly, children who are more than 12 months of age who do not have poor weight gain, fever, current cough or history of contact are unlikely to have TB and should be provided IPT. There are some contraindication, which is active TB disease. You have to rule out TB, active hepatitis, peripheral neuropathy, poor adherence to CPT, poor understanding of IPT. IPT cannot be provided. This will again be isoniazid 300 mg plus pyridoxine, and which will be provided on a monthly basis by ART Plus centers. Thank you for your attention. Please keep on sending your question with your email and we'll get back to you very soon. And thank you for your attention and your presence here.
Thank you, sir, for such a valuable and informative session. It is requested to all the participants to do the e-poll, which will be displayed shortly on the screen.